Good evening, everyone, and welcome back to the Lipid panel. My name is Dr. Guy Mintz. I am the co-chair of programming for the Lipid panel, working alongside Dr. Merle Meyerson. The Lipid panel was conceived as a lipid clinic conference on a national scale. For those of us who are lucky enough to have in-house colleagues, Lipid Clinic Conference is a great way to debrief after a busy clinic, to review diagnostic approaches, how to interpret clinical findings, and generate therapeutic strategies, and most importantly, to all come together with colleagues. For the rest of us who feel like we're on lipid islands, conferences like this remind you that you are not alone. If you have cases that you want to be presented at future conferences, please email with your suggestions to cme@lipid.org. If any of you wish to participate as moderators or panelists, please email the same cme@lipid.org. In this series, we will review common presentations of rare diseases, atypical presentations of common conditions, sometimes even common presentations of common conditions, and we'll try to cover as many clinical topics that every lipid specialist needs to know. The series is meant to be a monthly coming together of experts with NLA lipid scholars and early career lipid specialists with their more experienced colleagues. Look for our schedule posting for the final Tuesday of every month. As I said, we took a vacation this summer and we're starting our first conference today with a very interesting case and a superstar panel. Our moderator this evening is going to be Dr. Liebeskind. She's board certified in internal medicine and pediatrics and was one of the early diplomats in the American Board of Clinical Lipidology. Dr. Liebeskind started the combined pediatric and adult lipid clinics in Northeast Wisconsin in 2006, and also serves as clinical program director for heart and vascular services for St. Elizabeth Hospital in Appleton, Wisconsin. She is an adjunct assistant professor of pediatrics with the University of Wisconsin School of Medicine and Public Health. Our panelist tonight is Dr. James Trippi, who's a cardiologist and lipidologist, currently on staff at the Complex Cholesterol Center, the Vascular Institute of Extension, St. Vincent's Heart Center in Indianapolis, Indiana. He is the immediate past president of the Midwest chapter of the NLA. Mariana Henry is a first-year internal medicine resident at the Weill Cornell Medical Center. She studied nutrition science at the University of California, Davis, and then earned a master in public health and chronic disease epidemiology at Yale. She earned her medical degree at the Geisel School of Medicine at Dartmouth. And it's my pleasure to welcome our panelists this evening and all our colleagues joining us in tonight's discussion. So with that, I'd like to introduce Dr. Liebeskind, who will start the program with Dr. Mariana Henry.
Hello, good evening. I'm Ann Liebeskind, and I'm looking forward to discussing a really great case with you all tonight. So we'll get started. So as mentioned, our speakers are Mariana Henry, Jim Trippi, and I'll be moderating for us on a seldom suspected cause of coronary artery disease. I'll turn it over to Dr. Henry.
Thank you. So this is a patient who comes into clinic. This is his outside hospital case history. So he's a 41-year-old male with past medical history of hyperlipidemia. He was diagnosed with coronary artery disease in October of 2022. A left heart cath was done and medical treatment was advised. About a year later, in 2023, he had an NSTEMI. During that time, he was found to have blockage in 10% of the left main coronary artery, blockage in the 50% blockage of the left anterior descending artery, and 100% blockage of the proximal obtuse marginal artery. He had a PCI and in the left circumferential artery and as well as the obtuse artery with PE stent. He had a consult to vascular surgery, and he had a femoral ultrasound, which was normal, and medical therapy was advised for an LDL of less than 70. In January of 2024, a year later, He had a repeat radial left heart cath, which was unchanged. Slide. So given all that history, he comes into the lipidology clinic. He's middle-aged, he's asymptomatic. He has a family history of premature atherosclerosis, mainly among the men. His paternal uncle had an MI at 40. His paternal cousin had an MI at 31. He is a physician and he notes some increased work stress, and he's very concerned about early atherosclerosis, and he feels very motivated to improve his cardiovascular risk.
So Dr. Henry, I'll interrupt here and say, what strikes you about this case? And is this your typical patient that you've seen in your career thus far?
Yeah, I mean, I'm very early in my career, but he is very unique. He's very young. I will go into in the slides, but I'm curious more about his exercise and his habits, diet, smoking history as well. But again, having caths that early is quite remarkable, and I'm curious about what led to that for him.
Absolutely, me too. Well, let's move on.
Okay, for his past medical history, he has GERD, otherwise nothing else. Surgical history remarkable for wisdom tooth extraction, no allergies. He's been on atorvastatin since 2022. He was at 20 milligrams, and then in December of 2022 was increased to 80. Other medications, he's on cilostazol, 50 milligrams BID, clopidogrel, isosorbide, 30 milligrams, metoprolol, succinate 25, other multivitamins, pantoprazole, and vitamin D. He is a never smoker, no alcohol use, no illicit drugs, and he's mostly sedentary. Slide. For his vitals, he's about 5'11". His weight is 180 pounds with a BMI of 25. His vitals are his blood pressure is 112/72, heart rate 85, and O2 sats is 96% on room air. The physical exam is unremarkable, and he doesn't have any signs of hyperlipidemia, including xanthomas, corneal arcus, etc.
May I interrupt here and just say, we were especially concerned that he might have familial hypercholesterolemia, and that's the reason for looking for the external signs of hyperlipidemia like corneal arcus or pendant xanthomas.
And Dr. Trippi, what were some of the reasons that you were suspicious for FH at this point in time?
Again, he came from an outside hospital. I had limited information available. His cholesterols were, we were able to dig into the records and find they were mostly normal, but that was after therapy. I never did find a baseline cholesterol. So there's some concern that there could be familial hypercholesterolemia.
And I'm assuming because of the very young presentation and the strong family history, that those are some of the hallmarks that had you concerned?
Absolutely.
Thank you. So again, other outside workup that we had, unfortunately, it's a little piecemeal given the presentation, but he had an EKG, which was normal. His chest X-ray in 2022 was also normal. He had an echo in 2023 and it had an EF of 55%, normal diastolic function, and then trivial tricuspid regurgitation. He also had a lower extremity arterial Doppler, which showed scattered small eccentric tibial artery plaques.
So it's important with this echo that at the time of his myocardial infarction, he had normal left ventricular systolic function. So there was minimal left ventricular impairment after this myocardial infarction.
And something Dr. Trippi and I were talking about was whether there was a cardiac CT. Unfortunately, there wasn't, but that might have been helpful info for us as well.
Mm-hmm.
And I think this is a great example of sometimes when someone presents like to a lipids clinic, you weren't a part of the initial workup, and some of those things that you would have loved to have had that information, you just kind of have to move on. You don't have it, right?
Correct. Some more outside labs. His cholesterol in 2023 was 119. His HDL was 35. Triglycerides were 131, and then the LDL was 61. And this is all while on atorvastatin 80 milligrams. His urinalysis, CBC, BNP are all unremarkable. His high sensitivity CRP is 1.3 or average, and his LDL-P was 900. Testosterone was also normal, and bilirubin as well. And his vitamin D is 27 or deficient.
Now, what would be a reason for either of you to have checked the vitamin D, for example?
Vitamin D is, I've seen a few cases where very deficient vitamin D levels are associated with statin intolerance. Now, he's already taking atorvastatin 80 milligrams and doing fairly well, so perhaps it was not necessary, but vitamin D is part of lipid production, so there may be some factors, and especially involved with statin intolerance, that I think bear assessment. What do you think, Anne?
Yeah, I agree. And it piques my interest that, as you mentioned, this was outside before this individual presented to you. Someone who was taking care of him was thinking of some advanced testing here. They were thinking about inflammation. They were thinking about what was the best way to manage those lipids and looking at some kind of advanced testing for that. So it piques my interest that they were thinking of some of these things and had that data ready for you. Shall we move on?
Sure. Okay, so other outside workup, protein C, factor V Leiden, ANA, cardiolipin, PTT, all normal. Same thing with hepatitis labs. Folates and B12 also normal. His lipoprotein insulin resistance is 47 and normal is under 45.
So ordinarily, I would not order all these anticoagulation studies, but they were looking for a possible source of atherothrombosis. Unfortunately, again, nothing was of interest here.
It's certainly more information than we usually would get, right? But
Mhm.
but again, you have to credit someone for really thinking hard. This was a physician colleague, I guess, too, so they maybe didn't want to miss anything here. But they were thinking, and it's a lot more information than we would normally have. But it certainly helps the plot to thicken of why this individual is presenting with such advanced disease so young.
Okay. So the lipid, sorry, the
You have to click each. There we go.
Thank you. Okay, so his LPA is 9.7, which is normal.
And it was this lab work that you ordered in clinic when he presented to the lipids clinic?
Yes.
Mhm.
Ordinarily, in a young person like this, I would almost always suspect high LPA as the culprit. And here we have a very low Lp(a) level, surprisingly.
Mm-hmm.
And I agree, this is becoming more standard workup for people who present like this.
Yep.
Any commentary on the type of LPA, the nanomole per liter? Is that the one that's available to you and preferred for you?
Yes, Lp(a) in nanomoles per liter, I think, is becoming the more accepted form of measuring Lp(a) as opposed to milligrams per deciliter. So nanomoles per liter is often considered to be similar to the milligrams per deciliter divided by 2.5 or 2.6. So milligrams per deciliter is almost always lower. The problem is where patients go to different laboratories and have the LPA measured in different ways, and they assume that they're using the same label, but there can be quite a bit of confusion amongst physicians and patients if we're using different labs and there are different ways to measure the concentration versus the number of or the weight of the LPA particle.
Absolutely. And where I see it often is family members comparing. They recommend that their family go get screened, and then they start comparing numbers, but don't realize they're in different units.
Again, his CRP is 0.39, which is in normal limits. I think
And
there's more.
yeah, and what was the thought with the CRP and getting that again? And how often do you order that in clinic?
I think this is a fairly standard measurement, certainly in initial presentations, an Lp(a) and a measure of C-reactive protein, a kind of generalized body-wide inflammation test is certainly appropriate. Anything over 2 is associated with certainly much higher cardiovascular risk, seen early on in the Jupiter trial, and since then many other studies have shown a high CRP is just as related to atherosclerosis as a high LDL cholesterol.
This is certainly an individual where I wouldn't have been surprised if it was elevated, right?
Right. Mm-hmm.
Okay. ApoE is 65 or optimal.
And how does this help in evaluating the total therapies that are already having been implemented? Where do you use the ApoB?
Certainly, ApoB is a way to measure cholesterol and atherogenic particles in a different way. LDL cholesterol may be at the threshold or below the threshold, where the ApoB may be actually above the threshold if there are a large number of particles. ApoB being a way to count the number of atherogenic particles, that being LDL, remnant lipoprotein particles, VLDL, etc. So ApoB is a better indicator of atherosclerosis, and here we have a much lower and a normal number of particles.
And I think it's a good opportunity to mention that the National Lipid Association recently posted a paper that was a very nice overview of ApoB, and I'd encourage people to go to the website and take a look at that if they have questions about it. And many of our colleagues put some hard work into that, so it's a really great primer for that.
And his lipoprotein-associated phospholipase A2 is 123 or optimal.
A measure of vascular inflammation that we occasionally obtain, and again, very gratifying result at this point.
And with that, you said occasionally obtain. Was that because of the extensive nature of this individual's presentation that you decided to do that, or how do you decide when you order that?
It is just a way to look beyond the body-wide inflammation, and I just trying to do everything we can to get a better handle on what his issue is. It doesn't look like inflammation is a problem, and certainly at this point, then considering an anti-inflammatory agent like colchicine seems to be out of the question.
Vitamin D this time is 43, which is normal.
Mm-hmm. And he's been taking vitamin D.
Yeah.
Excellent. So what's left at this point? You've done some pretty extensive workup. He had some pretty extensive workup before that. He's on a pretty good kit of therapies. Where did you go from here?
Well, the situation is very unique. We have a physician here who is very motivated to try to find an answer as to what's happening in his family and to himself, and he wanted answers. I offered to do an ApoE test, genotest, which looks for the ApoE4 genotype, the Alzheimer's disease gene. He understood what that meant, but his main concern was this severe degree of atherosclerosis now, and worrying about Alzheimer's disease 2.5 decades from now was his least concern. So he said, let's find out.
And I think something I think about with this case, especially with the new prevent calculator, it would have, like, I think about how maybe when he was 30 or so before all this happened, it might be how he would have fared on that tool, and what things might have looked like too. So to me, it encourages me to use that calculator and think about it more in clinic.
Yeah, I think it's a great point that we heard even recently at the FNLA conference earlier this month. One of our colleagues presented from the American Heart Association on the prevent calculator and what it takes into account. And so it's a shift in thinking to start to think about using a different tool. And I think I'm stuck. There we go. All right. So you mentioned another test was performed, and that was earlier this year, right?
Yes. And indeed, here we have the patient being heterozygous for ApoE4. So just in summary, a really interesting situation of a young, middle-aged male with terrible family history, with minimal cardiovascular risk factors. When we think of his LDL cholesterol being 61 on atorvastatin 80, that would probably infer a baseline LDL cholesterol of about 120 or 125, assuming a 50% reduction in LDL. So LDL cholesterol was elevated, yes, but not severely elevated as you see in a patient with familial hypercholesterolemia or some polygenic hypercholesterolemia. So LDL cholesterol was up. He's sedentary. His testosterone level at 245 was below the level of 300 nanograms per deciliter, which is often considered hypogonadism, but his free testosterone was normal, so that was equivocal. And then he had this minimally elevated insulin resistance score, so maybe a touch of metabolic syndrome, but still nothing that would seem to lead to this severe degree of atherosclerosis. I mean, I see people like this all day long, every day, and they don't have atherosclerosis like this. So the E4 may be involved. So let's move on then, Ann. So apolipoprotein E is coded by the ApoE gene on DNA. It codes for a 299 amino acid protein. It has an N-terminal that binds to the LDL receptor and to the LDL receptor related protein. The C-terminal is attached to triglyceride-rich lipoproteins like chylomicrons, VLDL, remnant lipoproteins or IDLs, and less so to LDL and HDL. As a result, its main function is to clear triglyceride-rich lipoproteins from the circulation. So we need ApoE functioning. And we see that little diagram below. So here is a little summary of how to measure apolipoprotein E. It's done by polymerase chain reaction gene sequencing, where you look at all the DNA in the region of the ApoE gene, or it can be done with protein measurement using an ELISA method. That's a little bit less accurate, and yet it's much less expensive. Measurement of ApoE is available through many genetic testing companies and also through large reference laboratories. In fact, one of the national reference labs includes the ApoE genotype in their cardio IQ panel. So when you're looking for risks of cardiovascular disease, it's just part of that panel where it's ordered very frequently. And then this is just amazing to me. There is a direct-to-consumer company that offers an ApoE test without a doctor's orders and without any genetic counseling before or after. So all these tests run between, I don't know, $99, and I saw one as high as $500.
And I think that's an important part of our discussion tonight is the fact that this isn't necessarily a mainstream lipid clinic test that we're ordering frequently, but patients can come in with this already done. They can get it on their own. It can come in some panels that you may not even realize it's on or have breezed past in the past, or some other colleague has ordered it. So it is something that comes up more and more frequently, it seems, and it's important to have some handle on what this is and what to do with it.
Can we bring up the polling question?
Absolutely. So we're going to ask the audience here. So, and this is a new feature for us. Do you order ApoE genotypes in workups of patients with atherosclerosis? So to hear out there if there are people who are doing this periodically or regularly, are you ordering it on some patients? Okay, so I'm not in the minority here of not ordering it regularly. So 90% of people are saying no, that they're not ordering it currently. There are a few people out there who are, and they might chime into our discussion later.
So there are three forms or alleles of ApoE, the E2, E3, and E4 varieties. Now, persons inherit one allele from each parent, so there can be heterozygous forms with E2, E3, E2, E4, or E3, E4. If a person inherits the same allele from both parents, then they'll have homozygous ApoE2, E2, or E3, E3, or E4, E4. Now, ApoE3 is the most common allele, and it's found in about 77% of persons. It's functionally neutral, and it is the normally functioning ApoE. So it's necessary to clear triglyceride-rich lipoproteins from the circulation. Now, ApoE2 is rare. Only about 5 to 10% of the population have an heterozygous E2, and only 1% have a homozygous E2. E4 is more common, anywhere from 10 to 25% of the population. This really widespread, I was able to determine from numerous papers where it seems as though there is no consensus as to the frequency of this. In any case, everybody's fairly in agreement that the homozygous E4 is about 2% of the overall population. So E4, about 2% of the population. So what is this E4, the Alzheimer's gene? It's a substitution of just one amino acid, just one out of the 299 at position 112. As a result, it increases LDL cholesterol. And it's postulated that this may be from enhanced binding to VLDL and other triglyceride-rich lipoproteins, and therefore there's reduced lipolysis by lipoprotein lipase or endothelial lipase. There's also faster LDL catabolism. All this leads to downregulation of LDL receptors, which we know would be fewer LDL receptors clearing out LDL from the circulation and thereby increased LDL cholesterol in the circulation. In fact, carriers of ApoE4 have the highest total cholesterol, LDL cholesterol, and the lowest HDL. Even though they have the poorest profiles in relation to the cholesterol they consume, in the PESA trial, progression of early subacute atherosclerosis trial, the trial by Dr. Valentin Fuster on 4,000 patients in Spain over a decade, looking at patients, they found the greatest improvement, especially in young persons, with improved lifestyle and diet changes in these E4 patients. But they also noted E4 patients have increased coronary atherosclerosis, and the patients with ApoE2 have decreased coronary atherosclerosis. E4 also has increased carotid atherosclerosis in other papers.
So Dr. Trippi, does this open the window then for discussion about lifestyle changes as being particularly important in a patient like this?
I think it's absolutely important in that these patients respond very quickly, and I think as we wrap up this case, we'll see that as well for our patient. But they respond very quickly to lifestyle changes, and perhaps knowing this, as well as considering the neurologic situation, as we'll get to in a moment, is important in terms of lifestyle. So the question arises then, is E4 contributing to atherosclerosis beyond just increasing LDL cholesterol, or is there some other reason why there's more atherosclerosis? Well, ApoE4 carriers have increased inflammation, and there's increased inflammatory responses. There's also smooth muscle and macrophage activation, which is present in the atheromas in these patients with E4. And there's increased oxidative stress. So there are more oxidized LDL particles, which are all proatherogenic. Is this then a reason for these patients having more atherosclerosis, or is this just from the LDL cholesterol? Further research is necessary. Now, this may come as a big shock to lipidologists, but ApoE is unbound to lipoproteins and found in the lipid-free state. In fact, one author says ApoE is ubiquitous. It's made in the liver, vascular tissue, peripheral nerves, the brain, microglia and glia cells, and astrocytes. As such, ApoE is important for regulating the lipid levels in neural tissue. And it's essential for neural development and also repair. You can imagine, the long nerves with all that insulation have lipids as part and parcel of the insulation. If there is dyshomeostasis of the neural lipids by ApoE4, it leads to increasing and worsening of diseases such as Parkinson's disease, the chronic traumatic encephalopathy, the football player's disease, chemotherapy-induced dementia, Lewy body dementia, peripheral neuropathy, genetic diseases, and even long COVID syndrome. So ApoE4 is involved with all these neurologic diseases, as well as it is the strongest single genome risk variant for late onset Alzheimer's disease. And there's the name of the Alzheimer's disease gene. Now, ApoE2 has a 50% Alzheimer's disease lower risk than even ApoE3. ApoE3 is kind of the baseline risk for Alzheimer's disease. But ApoE4 is dose dependent in its increase of Alzheimer's disease. So those patients who have heterozygous or one copy of E4 have a 2 times higher risk of Alzheimer's disease. Those patients who have homozygous E4 have a 9 times higher risk of Alzheimer's disease. This patient by Juan Forio noted that homozygous patients for E4 are a distinct genetic form of Alzheimer's disease. he noted that almost all patients with homozygous E4 had Alzheimer's disease pathology and biomarkers by age 55. And almost all had beta amyloid in the cerebrospinal fluid by age 65. 75% of them had beta amyloid brain scans by age 65. And the average age of symptom onset for people with homozygous E4 is 65 years, which is shocking.
Yes, and when was that data from? What was the
This in the last year.
in the last year? Okay.
So the ramifications of ordering an ApoE genotype and a 2% chance of uncovering a very high risk for Alzheimer's disease is not to be taken lightly. Therefore, genetic counseling before ordering the ApoE genotype and then after the test results are returned, I think is essential. So a good genetic counselor needs to be part of this. Also, just the ethics of this are just fascinating to me. Here we're looking for a risk enhancer, thinking of atherosclerosis, and completely, probably not even cross the idea of late onset Alzheimer's disease probably didn't even cross our mind, or the test was just ordered as part of a panel, and it may uncover a very high risk for late onset Alzheimer's disease. And one genetic company that does a wide panel asks if you want to hide the ApoE4 genotype on patients. And I don't know about the ethics of hiding things from patients. I'd love to hear what people think about that. I don't know if you just don't want to order it, but here we go. So it's very important to get patient selection and be careful that the patient has a psychologic ability to cope with the diagnosis.
So let's move on and talk a little bit more about this patient then. Dr. Henry, do you want to close this out for us?
Sure. So at present, the patient is asymptomatic. He's exercising and active. He's very committed to his long-term health. He's following his medical regimen. So as we saw previously, he was on atorvastatin 80. Now in September of this year, his total cholesterol went to 66. His HDL is 47, his triglycerides is 53, and his LDL is under 10. He's on evolocumab 140 every 2 weeks, atorvastatin 80, and ezetimibe.
And so the therapies definitely got more aggressive here, and we're seeing a lower cholesterol level. How were things going with lifestyle, and how would you approach with that?
He is really trying, even though he works really odd hours, he was a junk food partaker in the past, and now is very careful about being on a low cholesterol, low saturated fat diet. He does exercise. He's lost some weight, so that's wonderful. And then the question is, why push to even a lower LDL cholesterol in this person with very significant atherosclerosis? It seems to me that an LDL cholesterol of 61 is adequate. It's below 70, and that's the guidelines. But in a patient with a fresh myocardial infarction at a young age, with these findings, I believe an LDL cholesterol should be at least less than 55. And I am encouraged by Bicchieri's trial that was in JACC in 2023, when he looked at patients with a recent myocardial infarction, and atheromas were seen to have triple regression when the LDL cholesterol was decreased to less than 30 with a really thorough medical regimen like this. So I believe the guideline for this patient should be less than 55, and therefore why trying to get the LDL cholesterol as low as possible is the emphasis here.
There's a great question from the audience on why the ezetimibe, and was that added before the evolocumab, or was that simultaneous and just trying to drive this down as fast as possible? What was the decision thought there?
Yeah, it was just whatever he can tolerate to get the cholesterol as low as possible. That LDL cholesterol being the only thing we can alter here. We don't have an ApoE therapy for patients with atherosclerosis, although there are therapies for Alzheimer's disease and ApoE, but that's probably a whole different topic to enter.
Now, would this be someone that over time you might back off and stop the ezetimibe on, since he's had such a complete response, or how would you all think about addressing this?
Personally, if it's well tolerated and not too expensive or inconvenient, I would go for 5 or 10 years. At that point, then it's very possible doing, for example, a coronary CT angiogram with FFR. If we see the plaque has largely been regressed and is absent, then I believe it might be possible to back off on some of that therapy.
Now we have a good question also from the audience, and anonymous. I would encourage people to use their names. We like to get to know people here as well. But we have a question about, thank you for the excellent presentation. As you presented, up to almost 1 in 5 in the Caucasian population has this ApoE4 heterozygosity. So this patient's disease and family history is FH level aggressive, they're saying. And so how can we attribute this to simply the ApoE4 as the risk modulator here? And, you know, is it that nothing else showed up, so this is kind of what's left? So what do you think the likelihood is that that is a significant component of this case?
Well, it is the risk factor that's left. And it's fascinating. In that PESA trial with 4,000 some patients, the ApoE4 patients had an LDL cholesterol 8 milligrams per deciliter higher than ApoE3. Now, it was 23 milligrams higher than ApoE2 patients. But just 8 milligrams higher, was that enough to cause all this? Perhaps yes, perhaps no. I don't have any other way to assess this, and I don't know of anything else to evaluate. But I would certainly be open to having anyone else consider or offer further testing or evaluation of a patient like this.
We also had a question from the audience if there's any correlation between LPA and ApoE4, knowing that in their patients they've seen LPA present with carotid atherosclerosis, coronary artery disease. Have you seen anything in the research you've done about any correlation between the two?
I can't say that I've seen anything that notes. So, you know, both of these disorders are about 25% or less in the population, maybe 20% for LP little a, and maybe average 15% for ApoE4. So then we're talking, you know, the combination of the two just by chance would be, you know, probably less than 5%. So. And I did not see any article that related the two.
And it is tough, understudied and underreported for some of these conditions. So how much is it attributing, and how much are we missing it? We just don't know, perhaps.
Mm-hmm.
Another question is mentioning the possibility of HDL efflux capacity regarding how aggressive his ASCVD is. So I think we're starting to get into the, you know, what are we missing and what's out there on the frontier that we might think about in this patient going forward.
Very interesting. That is a research assessment as far as I know. I don't know of any commercial lab that does HDL efflux.
Yeah, other questions. Do you think that everyone should take ApoE tests early in their life or just wait until some abnormality is seen? So more broad screening?
You maybe you might want to put up the second polling question.
I think that's a great segue into that. So our second question is, would you wish to know if you are at risk of Alzheimer's disease by ordering an ApoE genotype on yourself? We'll ask the audience to give us their thoughts.
Oh,
And
interesting.
we have some believers in the audience now. 69% saying yes, 25% no, and some aren't sure, are kind of on the fence. I think I'm with the unsure. I'm still not sure how much I would want to know that.
You know, I don't want to just, you know, be hanging crepe here and being a real downer about this because Alzheimer's disease research is progressing. In just the last year, donanemab, an antibody to beta amyloid in the brain, has been shown to slow Alzheimer's disease. And they are actively recruiting human volunteers. This is not just for animals now, human volunteers for gene therapy to convert ApoE4 in patients who have homozygous E4 to ApoE2. So there is hope on the horizon.
Absolutely. Are there any materials that you've used, like in this patient, for counseling that would help them if they don't have access to a genetic counselor?
No, we did send him to a genetic counselor. That's beyond my pay grade.
I know one resource that I could mention that I've seen is the Mayo Clinic has a nice genetic Alzheimer's disease test summary for patients that really talks about some of the genes that have been identified, and was somewhat reassuring but informational as well. So I've seen that one, and I don't know if there's anyone in the audience that has any other materials there. So we've got some more questions rolling in, but let's just do our last slide. Is there anything else you want to talk about with the case presentation, Dr. Henry or Dr. Trippi, as far as this particular patient? We cover it pretty thoroughly.
Yeah, I think we did. I think one thing that Dr. Trippi and I had talked about is just the role of stress, and being a physician, as many of us know here, can be very stressful, and if he has a lot of night shifts also, that can impact things. So it's something to think about too as well, and how that interplays with diet and exercise.
Absolutely.
So in summary then, ApoE4 can increase lipoproteins, certainly LDL cholesterol, and thereby increasing atherosclerosis. It's a risk enhancer. Thinking of it similarly to lipoprotein little a. But ApoE4, as opposed to LP little a, is associated with neurologic disease and late onset Alzheimer's disease. So let's be careful when we're ordering ApoE genotype to include some kind of genetic counseling, and that in those patients, 2% of patients who might have a very high risk for developing Alzheimer's, that they get a neurologic referral and they be considered for biomarker-guided Alzheimer's disease therapy. That is the beta amyloid antibiotic donanemab that's available now. So therapeutic lifestyle changes do help certainly with atherosclerosis, and with these ApoE4 patients, maybe even more than usual, reducing the lipoprotein as a result, and it also might decrease some of the complications with late Alzheimer's disease. So some of the papers noted that decreasing the lipoproteins seemed to slow some of the late Alzheimer's disease complications.
Thank you. Couple other great comments here. We have Josh in the audience who has some background in this apparently, and is saying that ApoE4 carriers in several studies have had higher markers of steroid absorption, as well as CSF PCSK9 levels, and also references potential for some higher LPA levels in E4 homozygotes that he's seen compared to E2 homozygotes. So thank you for that commentary, that we have someone out there that's read some additional information about this or studied it, perhaps, has some extra expertise. We also have
and I would also interject that I've seen where patients with homozygous E4 may even have some breakdown of the blood-brain barrier, so that lipids are able to transverse the blood-brain barrier at a higher rate.
Another question that I think crossed my mind as well here is there any role for genetic testing for FH in this individual? On statin, the LDL was 60s, LDL particle numbers were still high, and wondering if that untreated LDLP would be higher, and maybe in the FH range, or if this person, since we didn't have the full baseline, could have been a surprise hyper responder to the statin and maybe was higher to start, or has one of those presenting with a lower LDL, but actually does have an FH gene. So was that discussed or thought of in this patient, of maybe doing some additional testing for genetics?
Well, again, with what I would assume was, or infer, that the baseline LDL was 120 to 125, and they responded dramatically to lipid-lowering therapy. That is very atypical for familial hypercholesterolemia. And so I suppose this could be a very unusual cause of early atherosclerosis, but isn't familial hypercholesterolemia just the LDL cholesterol being high and we've reduced it? So I'm not sure if the FH determination would change anything. And in fact, just thinking about this, did the ApoE4 change anything that we would do here? Really, the whole point is getting the LDL cholesterol as super low as possible. And so it did, I think, give the patient some ownership, some explanation, which he was looking for, as to what was affecting his family, perhaps. And I think that's probably more the benefit than anything physiologic or lipid-wise.
And I think that's something that could be an argument maybe for the FH testing, is that if there was a gene there, that perhaps familial counseling for that as well. And I think that's what our next question was, is they were interested in your recommendations for this patient's children and how they should proceed with any further testing or future treatment.
Well, there's a 50% chance of transmission of the E4 to any offspring. So that is a consideration. I don't think it's probably appropriate for a very young child. Maybe upon entering adulthood, that might be a consideration. As I remember, I think he just was a new father. And so less than a year-old child at this point.
And so I would advocate, as I always do, for pediatric screening. That child now has a direct family member with premature disease. So starting at age 2, they could have targeted screening and follow their lipids and all their cardiovascular risk factors. So I think it was a great question about what you can do with the children and when you can catch and do something different than the father was able to do, not knowing that future. Dr. Mintz, do you have anything to add to our discussion tonight?
Well, I think it was a very impressive discussion. I'm still in awe of the three of you, because I don't think too many of us run into ApoE, especially the way it was presented this evening. So I'd like to thank everyone, Mariana, Henry, for presentation, and for an outstanding moderation, and Jim for your expertise in discussing this case in detail. For those in the audience, I want to thank you for joining us this evening, and please take credit for your CME and mark on your calendars. The last Tuesday of the month is lipid panel time. I believe the last Tuesday in October is October 29th, right before Halloween. So that should be a very interesting lipid panel for everyone. This is also a recorded program. So if any of your colleagues would like to learn more about ApoE, go to lipid.org and you'll find it there. So again, I want to thank everyone for an expert panel this evening and everyone for joining us. So thank you very much.